Just moving along, it's my pleasure to introduce Joanna Wright, CPC, who's a certified coding educator and compliance specialist with more than 14 years of experience in the healthcare compliance industry. She currently serves as the audit compliance manager at the Harvard Medical Faculty Physician Organization, where she provides oversight of the audit compliance program. Please join me in welcoming Joanna Wright. Thanks so much.
They always put us up against council, so it's always fun.
Get this off for you.
Always. I have many slides today, but I think the most important slides that I can talk about is documentation, because you've learned documentation from a medical standpoint, how to take care of the patient. And I'm here to talk about from the billing and coding side, which those worlds clash very often. We often wonder who put the guidelines in place, who's looking at them, is there physicians on that board? And sometimes I question it myself. But my goal today is for you to walk away knowing that at the end of the day, next to taking care and providing quality of care for the patient, your second job is to document that service to the best of your ability. So we're going to get into the real crux of documentation guidelines. And the good news about this, they don't vary from state to state. What you'll hear today, a comprehensive history, is a comprehensive history here in Massachusetts, Florida, California, wherever you go in the United States, a comprehensive history is the same. Okay? There might be institute internal policies and protocols, but the CMS guidelines are the guidelines regardless of where you go. So we'll talk about that. We'll touch base on I-10 because we know it's a delay, the good old Affordable Care Act. Fraud and abuse ties in with documentation guidelines. The Sunshine Act and anti-kickback we may not get to, but there's slides in your handout, and you can feel free to contact me with questions and or our legal representative, Jill Watts. Her contact information is in there too. Okay. So my role here at the Harvard Medical Faculty Group is to keep the physicians and the tax ID safe. And how do we do that? In a court of law, you won't have a second chance to explain why you billed at that level. Your documentation is all you'll have to support what you did for the patient that day, what you ordered, what the medical necessity is. So you get one shot to get it right. It's, as I said earlier, it's the last piece of the puzzle. You want to make sure you fill in all the gaps in that documentation. Quality of care. It justifies the need, the order, any procedures you need to do. And at the end of the day, it supports the billing and the coding, that's my piece, to keep you safe from a federal investigation. I've gone through them. They are not fun. It's a lot of stress. It's a lot of money, a lot of money. And thankfully here at HMFP, we haven't had any huge refunds. We do refunds all the time because, again, if we go back and we see that a physician didn't document an order, didn't document or overcoded or upcoded, we have to do a voluntarily disclosure and refund that money saying, at the end of the day, we make mistakes. Our priority as clinicians is to take care of the patient. So if I didn't get in all my components in my note, well, I tried. So we say, okay, we'll refund that service because maybe it wasn't to the level of service that you billed for. CMS says this is in black and white, and their guidelines are not open to interpretation. They're black and white. If you didn't document it, you didn't do it. That is it. They will not say, well, the nurse saw you in the room with the patient, and we know that the hospital billed for, the scope supplies. No. If there's not a note, you didn't do it, and if you didn't document it, that's a false claim, and that can get you in trouble. And it's a whole big argument to get out of. So avoid it. Make sure you document. I'm going to sound like a broken record, but I can't tell you how many times a day I say to the attendings, and you can ask them, document your services. Okay. Our general recommendations, and council also supports this, education and training. We come in, you can ask the attendings, we come in yearly, 18 months, to do an assessment no one likes to be audited, but it tells us how you're doing. What's your bell curve? As a specialist, you should be maxing out at level 4s and 5s for new patients. For follow-ups, your peak should be around a 3 to 4, sometimes a 5, okay? If you're off the cuff or off the curve for a bell curve, you're going to get audited. That's an immediate flag. We get weekly requests saying, okay, we want to look at Dr. X and his documentation because he bills all 5s. Well, though patients are severe and come to you with complex cases, it's not always a 5. So we have to reel the physicians back in and say, listen, we need to be average on the bell curve, or we'll get audited. And sometimes we win, sometimes we don't, and that can be a refund. If it's found that you've willingly submitted a false claim, well, that's a whole nother level of triple fines and damages, and you don't want that. As new physicians going out, you don't want that. Okay, can we take questions along the way, or should we stop? Okay, any questions? I know you're hearing a lot today, so my goal is for you to walk out and say, I'm going to document to the best of my ability. So feel free to stop and ask questions along the way. Okay. So documentation requirements. So for a new patient, and you'll hear this again across the board, a new patient is a new patient that has not been seen by you or someone in your field, in your group or specialty within 3 years. Okay, that's really important to know. Sometimes you may not know. Sometimes a physician may leave and you may take over their practice and they are physically new to you. You've never seen them. But Dr. Shavitz saw them 2 years ago, but he's gone. It's still an established patient to you because it's an established patient to your group. Now, you may be able to bill higher because this is all new to you. You have to research the records. You have to look at all the tests and reports that previously was done. So you may be able to put that into your note and bill higher, but it's not a new patient to you. Okay, I'm going to play a little Vanna White here because I want to walk you through the elements, because this really supports, at the end of the day, how you bill your level. The attendings will roll their eyes if they've heard this 100 times. So, for a new patient, 5 levels, 1 through 5. Again, being that it's a new patient, a lot of levels fall here, between a 4 and a 5. So what this grid, and it is in the book, what it will show you is, first of all, you always need a chief complaint. I know that sounds very elementary, but believe me, I've looked at thousands of notes, and you don't know what's wrong with the patient in 3 pages of notes. Start with why they're here to see you. What's the chief complaint? It doesn't have to be a disease you may not know yet. Abdominal pain, bleeding, nausea, vomiting, diarrhea, whatever it is, get it in there. Your history of present illness. This is the adjectives you want to use. The who, what, and why, how long the problem's been going on. It's really 4 adjectives. There's location, severity. The patient, it hurts at night. I've taken a Tum. The patient, has been vomiting for 3 weeks now, off and on, after meals. All of that is describing what's going on with the history of present illness. And you need 4 adjectives. And I like to say the who, what, and when, and why. 4 of what's going on. Okay? Secondly, review of systems. This is critical because it's irrelevant sometimes. So they say you need 10 plus systems review. Well, as a GI physician, you're not looking at neuro, you're not looking at GU. Those other systems are irrelevant, and we understand that, and we push back so much that the government says, okay, if you document what is pertinent to you, whether it's negatives or positives, no fever, chills, diarrhea, vomiting, then if you say to the patient, listen, besides X, Y, and Z, how do you feel otherwise? Everything okay? And if we, the patient, say, yeah, besides vomiting, I feel pretty good. You can use the caveat of saying all other systems are negative. But you can only use that in combination with the others, positive or permanent negatives, okay? That's really important to know. So with that, all other systems negative, you get 10. So far we're at a 5. Past family social history, very important. Don't skip out on anything. You have to ask past family and social history, all 3. I will tell you, by documenting medication, that is considered part of past, so that's easy. Just by documenting your meds. You already have one. Okay, that's the 3 components of history. So if you have those, you're still at a 5. You're still at a 4. Yes?
How comprehensive is that social?
It can just be one element. Social, the patient works at BI, the patient doesn't work, the patient's married, single, is a teacher. Same with, alcohol. You can do alcohol and tobacco, but you don't have to. That's up to you as a clinician what you need to do. But you have to have one from each area for past family social. Yes? Oh, perfect. We're going to get it. That's the next slide. But that's great. Non-contribute. The word non-contributory is a bad word. Okay? And again, this is where the billing and coding world clashes with the medical world. It's a perfect word for you guys to use, but not when you're billing at these certain levels. Okay? Physical exam for 4s and 5s, which you should be billing at your patients. We need 8 organ systems. Remember, the neck is not an organ system. We have to fight with endo all the time because it is a system for them. It's not. If you're feeling for lymph nodes, put lymphatic system. That's a system. Okay? It's a game. This is all a game, and you have to play it. Okay? And I recommend wherever you go to get in contact with some compliance people and continue this training of guidelines. Okay. Any questions for the physical exam? Oh, thank you. Am I not loud enough? Okay, so medical decision making. This is the most important. This will make or break you, and you don't want to go in strikes. So this, at the end of the day, is what you will be called out on by the judge, by an attorney. These are all bullets. You did them or you didn't do them. They're in there or not. But this is it. This is why you are where you are. How severe is the illness? What are you doing for the illness? What tests are you ordering? What reports are you looking at? Are you bringing in reports from the general? If it's not documented, I can't say that you did it. And I'm not a clinician. I don't try to play to be one. I am a documentation expert, and I will read many of records and say, if you don't say it, I can't assume you did it. I think you did it, but legally I can't assume. So if it's not there, it's not done. Okay? And if for a level 5, if you don't have high complexity, you can't bill at this level, even if you have all these components. I just went through a huge battle with a physician who said, through the whole note, he was a nephrologist, stable, 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 patient's doing excellent, no new med changes. He billed a 4, which is moderate complexity. I said, we may know kidney failure stage 2 is very severe and could lead to 3 and transplant and often death. But today's visit, you told me in your note, stable, stable, stable. You can't bill a 4 or 5 on a stable chronic problem. There has to be something going on. That's your job to tell me what's going on. We get patient calls. I got at my EOB. The doctor spent 5 minutes with me, but he's billing a 5. The note needs to support the service, what you've done. Okay, any questions so far? Because this is really important when it comes to your billing and coding.
What's the distinction then between low, moderate, and high? It seems very subjective.
And there are more guidelines, but because I only have 20 minutes, I had to. The complexity levels. So moderate is, a chronic problem with mild exacerbation, or 2 stable problems with mild exacerbation. High is there's a lot going on. There's severe exacerbation. The patient's on a lot of medications that you need to monitor. The illness is life-threatening. Okay, many times if you see a patient in the clinic and you say, okay, we need you to go right to the ED, that's not a new 5, but that's going to be a follow-up level 5 because you're acting, you get paid for your knowledge, for your wisdom, for your schooling. So this is how you determine that, is saying the patient's at a moderate risk or a high risk. Yes.
2 questions. Does it help to talk about imaging and record?
Yes, it does. So you get credit for ordering or reviewing image, but you get extra credit for saying, I personally reviewed. Okay, so I always use the X-ray. If you're looking at it, put that, I personally reviewed. You get higher points, because it's all based on a point system. If it absolutely would, yes. So also, if you say to the, if you're looking at outside reports, patient brought in their documentation from the Brigham or the General, and you look at that, put that in. Reviewed outside notes. That goes towards your complexity. You're not just saying, oh, okay, yeah, no, we'll see you next week. You're being paid, the RVU is based on the management that you're putting in, you as a specialist are putting into it. So how do you show that? You have to document. Document you personally reviewed the reports. Document that you're looking at outside records. Document that your patient brought their spouse and they have 1,000 questions. Document that. That takes your time. And I'm not saying document 7 pages worth. This can all be done in a page and a half. Or make sure your fellow residents document it even better.
If we've seen them in like access, endoscopy, and then a follow-up up with them clinic, it's a follow-up.
It is a follow-up because you've had that face-to-face.
What if it's a second opinion?
So second opinion. So most insurance companies don't pay for consultations anymore. It's either a new problem, new patient, or a follow-up. So keep it in context that if you or someone in your group has seen them in 3 years, it's not a new patient to you. If they haven't, regardless of they've had 3 opinions, it's the first time you're seeing them, it would be a new patient.
So if they were seen outside of your like physical hospital, what do you think? Because, you know, I work at EU or the hospital, so someone from MGH or patient comes over and wants a second opinion. Is it a new patient to me?
If you have not billed them, yes. If our tax ID, BIDMC, GI has not billed them, yes. Okay. So for follow-ups, the same rules apply. Yeah. Do you have a question, Adam? The same rules apply, but you only need to meet the guidelines at 2 of 3 components. Okay? So not every patient is going to warrant an 8-organ system review. You maybe just saw them last month, and you may not even need to do a physical exam, right? And that's okay, because as long as you have the other components, medical decision-making being one of them always. So as long as the patient's coming back in, let's say every 2 months, you do a good history. You don't do an exam because they don't need it, or maybe they say, I defer it, I don't want it today. But the level still meets, the complexity is still at a moderate, so if they're coming back every couple months, obviously something's going on. You're following them for a chronic or an acute condition. So that's a moderate. You'd still be able to bill at a level 4, even though there's no exam. Okay? Or, and this doesn't happen, but you may not have a history. But you do an exam, and you have your moderate complexity. As long as there's 2 out of the 3, history, exam, medical decision-making, at this level, you can bill that level. Okay? So it's really important to really understand what level needs what. I say if you learn what a comprehensive history is, for who, what, when, or why, how bad, 10 plus systems, and you can again say all of the systems are negative if you've documented your pertinent. 2 of 3, past family social, 8 organ systems. If you learn that from the get-go, you'll be fine. It's when you start to say, well, I'm just going to document this, I'm just going to document this. For inpatient, it's the same, you're seeing the patient every day, right, for 2 weeks, for 3 days. It's the same information over and over again. They didn't really change from yesterday, the same medication. You still need to redocument. You can refer back. Up to 6 months, you can refer back, but you can't leave it, you can't omit it. Okay, that's really important. How are we doing on time? Okay. You can never refer to an exam, because that can change. Okay, but you can refer back to a review of systems, or past family social history. Okay, so my screen went blank. Documentation requirements. Oh, fancy. All right, so CMS states that you can document, we went over this, the review of systems, I won't get into this again, but the non-contributory. You cannot just say history is non-contributory. That doesn't mean you ask specifically the questions that are pertinent to you or the patient. You need to say non-contributory for colon cancer, non-contributory for diabetes. Okay? So you can use it, but you have to use it in the right context. That's really important. I have failed more physicians on non-contributory than I can tell you.
Can you just say something simple like non-contributory for other GI illnesses or GI malignancy? Or you have to specify?
You could say malignancy because that is specified, but I wouldn't say other conditions because there's 1,000 conditions that it could be. You know, I wouldn't look for ways out. I would learn the fundamentals of getting it right. Get a template in there, and you'll be good to go, honestly. If you start to try to say, well, what if I do it this way? It's going to get in trouble. And at the end of the day, our attorney might say, yeah, that's fine, but you don't want that call saying, oh, can you come to the chairman's office? You don't. You don't. Okay. Let's see. Medication, allergies count as past history. If there's no new changes from previous visits within 6 months, I would not recommend. This is not in black and white, but as the audit manager, I would not recommend going back a year because you could be, how do you remember Mrs. Smith from a year ago if her social history? Okay, so that type of information doesn't change. If you have a visit and a procedure on the same day, this is another hot issue. It's really important that you carve out your evaluation. Patient comes in, I'm trying to think of what type of procedure on the same day. What's the most common practice for a procedure on the same day of an office visit?
I mean, we could do a like SIG later on that day.
Okay, so
Things that vary, so they change.
yeah, okay, but let's just say the patient comes in, you evaluate them that day, and you say, okay, they need to be scoped. They're going to go later on that night. Your documentation, because I've seen some providers put it all into one. It shouldn't be. Patient comes in, here's the history of present illness, here's the exam, here's the medical decision making. Within that medical decision making, you're going to say, later on today or tonight, we're going to do a scope, we're going to do X, Y, and Z. Then your scope note. Don't mix the two. Because you're billing for 2 services, you want to be reimbursed for 2 services, the auditor needs to see 2 services. It's easy to do, to blend it all in. I see it a lot under the exam, but you have to carve those pieces out. That's really important. Okay? Any questions so far? I will recommend, if you're staying here at the BI, we do a really in-depth, detailed E&M training. I highly recommend it. In fact, you could probably do it anyway, even if you're leaving. It's a webinar. You dial in from home. You can dial in from anywhere. And it goes through all of this, but in greater detail. I highly recommend it because, again, no matter where you go, even in private practice, these rules apply. Okay. So that's the piece with, yeah.
So if you're going to proceed the same day, I thought there was a difference in reimbursement. You have to receive reimbursement if you have a hospital here.
The reimbursement is for multiple procedures on the same day. They start to pay the top procedure at 100%, 75% for the second, 50%. But the no, they don't. You have to put a modifier on to say that you did the 2. You want to be reimbursed for the 2.
So you get reimbursed the same.
Yes. Okay, how are we doing on time? It's up? Okay, so just FYI on the I-10, I'm sure you've all heard it was supposed to go in effect this October. Good old president delayed it. We spent millions on it, but just so you know it's coming. They said the new date is October 1st, 2015. What it means for you, greater specificity with your documentation. Okay, here's just an example of gastritis. It was 35.5, now it's going to be, well, in 10.1, it's going to be K2970, and bleeding has its own, we went from 15,000 codes today to 80,000. It's ridiculous. If you want to get out of healthcare, now's the time to do it. All right. I don't want to delay Dr. Chopra, so I will, if you have questions, feel free to reach out to me or Jill Watts. Okay? Thank you so much. Best of luck to all of you.